Okay, so we're finishing up week 8, but tonight is all about the mindset. As we get closer and closer to you guys getting into the lab, we're going to be putting more and more scenarios because in a couple weeks, believe it or not, you're going to be there. Okay. All right. So the patient has not arrived yet. And this is the most important part of the case. I want you to look at what's going on over here. Okay. This is you right here. All right. You are organizing, you're setting up, you're inspecting your instruments. Um, you got to remember to get your eye protection on, but that's okay. But the question I have for you in this image, has the surgery started yet? Just from what you see. That is correct. Surgery has not started yet, but we're still looking at safety. We're still having that patient in our mindset. Now, there's a couple questions that are going to be going through your mind as you're setting up. Okay, remember, this is us right here. All right. We're going to be thinking about the procedural steps. We're going to be thinking about, do we get everything on the surgeon's preference card? We're going to be thinking, do we have all the special equipment that has been requested? Looking at my circulator, do you have my backup sutures? If the patient will possibly need blood, is that available? And if we're doing some type of case with an implantation or an implant, is that ready? Okay. This quiet time where you're in the moment, where we're kind of going over our instruments, we're looking at our bag table, we're looking at our Mayo stand, this is our predictive time where we're starting to think of any and all possibilities that could happen for our procedures. But if we use this time poorly, right, we can expect delays. We can expect missed instruments, tension, contamination risk. Let's say this is a laparoscopic cholecystectomy. What do you expect before the first incision? Now, for the laparoscopic cases, we use what's called the Veris needle. I think that's a general, it's in the laparoscopic and general instruments to add CO2 into the belly, to expand the peritoneum so that we can get our trocars in, so that we can get our camera in, so that we can start the case. Other things with a laparoscopic case that you're already thinking about is your camera. Did you do a white balance or check your light source? You're already building up in your mind the steps. Okay. Now, for the exam, if the question asks something like, if I change one step in a setup, what can happen downstream? We're looking at cause and effect. Today, we're going to walk through the case from beginning or before the patient enters to the moment the incision is made. All right. Now, with that, we have our objectives, but we're going to have it in the form of a mission tonight. Okay. Everything happens before the first incision. And if it's done correctly, the incision feels almost easy, like, oh, we're already at cut time. All right. Now, we're going to look at this from what we see. We have our case plan. Okay. We have our preference card. But from what you know, what is this preference card actually telling us? I want you to be thinking of the surgeon's habits. I want you to think of the instrument variations. Sometimes the same procedure with different surgeons requires different equipment, different suture choices, anticipated implants. Okay. It's a recipe, or I would say a starting point. Now, we have to confirm everything is sterile before we open it. When you're in the lab in a few short weeks, and I think you guys are going to be going this module before you go, okay? In the lab, when you are checking your items, you are literally taking that package and you're looking and you're checking to see if there's any rips, tears, any type of moisture, strike through, anything that could make that item non sterile. You're checking equipment, making sure that your bovie turns on and off, that your suction is actually sucking. Okay. You're checking light sources. You're looking at that bovie, that ESU, making sure that it turns on. Because you do not want to have a case where you need a bovie and it doesn't turn on. You're also checking positioning aids. Go back to the positioning, um, even just the tables. Some tables require different items to be added with it. For example, if you guys are going to be doing a shoulder rotator cuff and the surgeon prefers the patient to be lateral, but it'll say lateral with beanbag, which is a lot different than just placing the patient in the lateral position. Okay. I like how you said this. Maybe have an external suction if Neptune doesn't work. A lot of times, some cases require two Neptunes. If you're doing a big spine case, you may have multiple suctions or, best case scenario, multiple Neptunes. When you're doing any type of arthroscopy, meaning shoulder scope, knee scope, any scope, they're going to have usually Neptunes because the suctions fill up so fast and you're constantly having to swap them out. So having a Neptune really does save time. Okay. Now, you do not open your room until it's ready. You scrap, you gown, glove, you set up, you do your count, and then we do the timeout. These are the elements that we're going to go over this evening. Now, this is one thing that I really have to emphasize. Surgeons do not speak in paragraphs. They actually speak in verbs. Okay? If you understand the verb, then you'll really kind of understand the case. So we're going to go over some of the terms you see up here. Not all of them, but some of them. Okay? I'm going to start with amputate because that's the first thing you see. By what you've studied in Mod 1 with med term, what does amputate imply about scope? So we take what we learned in Mod 1 and we're bringing it to Mod 3. Let's say the surgeon says we're going to amputate the left foot. In your mind, you're already thinking, what instruments am I going to need to have for an amputation of a limb? Then we think, what are we actually doing? Does that mean we're going to partially take off the leg? Right, we're going to completely remove that leg. Okay? So we look at a large scale. Now, if the surgeon says excise the lesion, now what are we talking about? Is it going to be still a large scale, or now are we thinking about something a little bit smaller, a little bit more contained, more clean margins? Okay. The instruments you set up for a left leg amputation are going to be a lot different than the instruments you set up for an excision of a lesion. Does that make sense so far? Okay. All right. Now, when we talk about resection, we have to think about how resection is different from excision. We look at larger portions. We look at segmented removal. We look at it could be an entire organ that needs to be resected. For example, you may be scheduled for a colon resection for one case, and right after that, you may have a skin excision with the same surgeon, both general cases. Okay? Let's move to connecting and fixing. This is where,
I'm sorry.
go ahead.
What does resection means?
Removal. So, a resection is
Okay.
you're actually removing a large portion. So, if we're going to resect part of the colon, we're going to actually remove portions of the colon. When we talk about an excision, I want you to think of, I'm going to go really small. Let's say you have a wart on your arm or on your, this thing, and we're just going to excise that particular wart out. You're not resecting anything because the skin, for the most part, is intact. But when we resect, like the colon, we're taking out large portions, most likely, and the anatomy is going to change. We can do a hernia, but we have to be careful with hernias because in peds, we don't necessarily remove. There's two ways to do it. A lot of times we can resect or remove the hernia sac, or in peds, a lot of times they'll put mesh and have it so that the skin heals and the protrusion or the protruding intestines kind of goes back in. So there's two ways. So with hernias, I have to be careful because of the different types of hernias. We have umbilical, we have inguinal. Um, and the approaches are slightly different, but you are thinking on the right path because a lot of times we will remove the hernia and the hernia sac. Because what happens is the intestines pushes through and it creates that sac. So when you remove the sac and close the skin, either through mesh or resection, then it will kind of allow like a barrier so that the intestines cannot protrude through. Okay, if that makes sense. Does that make sense? Okay. Now, you may get called. Me and Angel may be set up to do a debridement, and it's usually an irrigation and debridement. Okay, so let's say we had a patient come in with necrotizing fasciitis. We're definitely going to have to do a debridement. Okay, where we're going to remove a lot of that dead tissue. You are welcome, and any of types of contaminated debris. Necrotizing fasciitis is a little bit different because of the nature of the disease. With those particular cases, we are in there getting as we're trying to get to healthy tissue. And a lot of times we're doing a lot of debridement, getting rid of, I don't want to say the slush, but you'll be able to see the diseased tissue a lot. And we're just trying to debride until we can get to bleeding so that we know, okay, we are healthy. Now, for this particular case, would this be considered cosmetic or life saving? And I'm talking about that necrotizing fasciitis. Yes, this is life saving because the sucky part about necrotizing fasciitis is that it will travel the pathogens. They get that biofilm. You guys remember the micro, and then it goes and attacks and it destroys surrounding tissue, and then that tissue is destroyed. And then it just, if we don't cut it off, it can continue to spread. Okay. Now, anastomose. We're talking about hollow structures, bowels, or vessels. Okay. When we think about anastomose or bringing tissues together, from the instruments that you remember, what instruments would be used to bring hollow tissues together, any tissues together? There's going to be some of the things that you're trying to set up. Well, what do we need to suture with? What type of instrument is used for suture? And you notice I automatically go to the hand motion of it. So surgeons like stitch, right? So we need a needle driver, sutures, and if you're doing, a lot of times when we're connecting bowel back together, we're going to use vascular clamps, okay? But you are setting yourself up by just knowing what those cases are. If a surgeon says, we're getting ready to approximate the skin edges, would you be cutting or closing? And think about where we are during the case if the surgeon is talking about skin edges. So a lot of times I'm already getting my 4040 monocryl on a CT1 on my Mayo Hager needle driver, my suture scissors ready because we're getting ready to close. I'm also pulling my items off of my Mayo stand, putting things back on my back table. Once we get to a certain part, my counts are done. I'm getting ready to ask for my dressings. The only thing I want on my Mayo stand when we're getting ready to do that final stitch is really just my dressings, a wet and a dry, my dressings, and then they're going to hand me back the needle driver, the pickup, and the scissors. My back table is going to be pushed back already, and I'm ready to go. I'm ready for them. Okay. Now, remember, the case can't go on if they can't visualize. Okay. So if they say, I need exposure, what instrument do you think you'll be already preparing to can them? Like, I just need better visualization. Like, I can't really see. Thinking about the categories: clamping, cutting, retraction. Yes, you're going to be handing them retraction. If the field is starting to get bloody, what other item can you hand them as well? I don't know if I mentioned that this will be something, haha, yes, I was gonna say this is something we hand to the resident or whoever's in the room, just give them the suction, right? Because not only can they not see, now the field is starting to fill up with blood, okay? But we are gonna get ready for success, right? We know that the preference card is not necessarily a grocery list, it's more of a prediction, okay? So on the left side, we look at the case. We're doing a laparoscopic cholecystectomy. Before we look at instruments, we try to figure out what exactly is this procedure telling us about what we need for our setup. When we do any type of laparoscopic arthroscopic case, we have to have a tower. The tower is our home base because it's going to have our monitor. It's going to have our insufflation. It's going to have any other specialties that that surgeon may need. We know also that we have to have a camera and a light source. Remember, I said that we inflate the belly, so there's going to be some type of insufflative tubing. We're not going to necessarily use a general tray because it's a laparoscopic case. So we're looking at a laparoscopic tray. Are you guys with me so far? How this helps us break it down? Okay. Now, we also will need some type of trocars, 5 millimeter, 10 millimeter. That's usually what we use. Again, open or laparoscopic positioning because it actually matters. In an open case, we're in one position. For a laparoscopic case, we're in a different. For a laparoscopic case, you're going to be in reverse Trendelenburg, usually with a left tilt. But why? Why are we using this particular positioning for this particular case? I want you to think about what happens to a patient in reverse Trendelenburg. So what are we trying to do? Why are we putting this patient in reverse Trendelenburg? Remember about spatial awareness. Okay, we're trying to build it. We're trying to make sure that even insufflated, we have room to work around in the abdomen. Surgeon's card tell us who our doctor is. We've got Dr. Chen. This matters because Dr. Chen may have different variations than Dr. Smith versus Dr. Sines versus Dr. Hilfiger. Okay? This lets us know their instrument preferences. It lets us know a lot of times the sequence differences. Is every lap chole the same, do you think? Nope, exactly. It's not. It lets us know the surgeon's glove size, if there's an allergy risk. The entire room has to adjust for our surgeons. We had one doctor that had to have latex. Like, for some reason, all his gloves were latex. Okay. But if a patient is latex or the surgeon is latex, everything is latex free. The good thing is most of our stuff now in the operating room is already latex free, so that's not really a problem, but we still trust but verify, okay? Because it's not just gloves, catheters, drains, bands. We're checking all of that to make sure that they are indeed latex free. All right. Now we get over here, and this is important. If the patient has a high BMI, there's going to be some things that change. Would we use the same size trocars for, let's say, a neonate as we would a 250 linebacker? We wouldn't, right? So our linebacker, we need longer instruments. We need longer trocars. We need to make sure that we have the long, um, sometimes even blades if we have to go open. Okay. You're going to hear the term endobag, right? In any type of laparoscopic case, when you hear endobag, I want you to be thinking of specimen retrieval. We're also thinking about contamination prevention. We're trying to contain it. The other thing I want you to always remember for any laparoscopic case is your varus needle versus the open Hassan technique. I want you to think about what changes. It's really just about access and setup. Okay. Now, if the patient has a BMI of 42, remember we're looking at longer instruments, we're looking at a weight rated table, we're looking at additional supporting items for positioning. If the diagnosis includes something like acute cholecystitis, I want you to remember that there may be a possibility that that laparoscopic case can go open. So you're going to need extra suction. You're going to need more clips. You may even need possible drains. Again, we're breaking it down. Okay. Now, we look at the goal of surgery, and this is really important because this is also going to help you as you prepare for your cases. This is going to help you when you get back in Mrs. Hughes's classes and you're writing on the surgical procedures. All right. Now, if you're just doing a diagnostic procedure, you may be scheduled for a laparoscopy. All they're doing is going in and looking and seeing what's going on. They may get in and they may see adhesions, so then that laparoscopy becomes laparoscopy with lysis of adhesions. All they're going to do is spread the adhesions, burn them down, irrigate, close up. Okay. They're still going to evaluate. They're going to check the pelvis. They're going to check the liver. They're going to check all of the organs to make sure that there's nothing else going on. A lot of times they have found ovaries that have been just twisted and different things, and the patient will already be consented. Okay. If we're talking about reconstruction, you're thinking about implants, you're thinking about certain suctions, you're thinking about additional antibiotics in some cases. If you are doing a total knee, total hip, total shoulder, there's going to be cement that's going to be mixed. You mix the cement on your back table. Okay. These are going to be different things you are already having in the back of your mind. For repairs, we mentioned hernia. I think Miss Whitty mentioned hernias earlier. There's a couple different ways. But if you're doing a hernia, and you see hernia repair, especially if it's an inguinal hernia, the first thing you're going to be asking is, hey, doc, with or without mesh? That matters. That way, the surgeon already knows, okay, they're on it. We're on the same team. And then with the mesh, you'll have certain sutures that you'll add with it. Okay. If you are in a orthopedic case and you're doing a repair and you see a ORIF, which is an open reduction internal fixation, you're going to be asking things about fully threaded or semi-threaded screws. What plates are we using? Because there are different types of plates. There are different types of screws. You don't need to know the screw number yet until you're in the case, but these are things you're already thinking about. And if we come over here to removal, you're already thinking some type of specimen is coming off of my field. So I'm going to need either a petri dish or a specimen cup, labels already on the back table. All right. You're also thinking of the type of clamps. The clamps that you would need in ENT are going to be different from the ones you need in general, that are going to be different from the ones you use in ortho. And it's all about access and what the surgeon is trying to accomplish. Okay. Now, the good thing here is sterility begins before anything is actually sterile. If you move the room after opening packs, you've already increased the risk. Okay. So let's look at this room layout. What's wrong with moving the back table after the packs are already opened? What do you guys think? What could happen? If you just start moving, things can fall, contamination. It also violates that 18-inch rule because you want to have a buffer. Okay. Furniture placement is not cosmetic, it is actually kind of what we do to protect our patients. That 18-inch rule protects the sterile field, it buffers from the wall. Believe it or not, there is a lot of moving parts in the operating room. People are constantly coming in and out of your rooms. There's high traffic areas. Now, when the room becomes obsolete is once blue wrappers are opened. Okay, so you're looking at this. Before opening, there's flexibility. After opening, now we're talking about, I want you to think about this is the law. I am not going to be just moving things nilly willy. Now, no sterile items we know can be compromised. We try to prevent unnecessary movement. We test the suction before opening. We avoid trying to scramble. You want to make sure that you hopefully do not want to be the reason that there is a delay. You are going to be creating sterile fields in 5 or 6 short weeks. Okay. Nothing is opened until it's inspected. I cannot stress. I have seen students get hit on things like that. Like they'll just go ahead and open it without checking, verbally checking. Okay. Remember, your students, when you're getting the field, it's going to be muscle memory. You're going to pull it, check it, and open. But as a student, remember, you always want to verbalize. I'm checking the sterility. I'm checking to make sure there's no rips, there's no tears. Everything's integrity is intact before you open it. For items that were peel packed, you're looking at that internal indicator. Did it turn? Because a lot of times there's going to be additional instruments that are not in instrument sets. So they're going to have internal indicators. You're letting us know I'm checking the internal indicator if applicable as well. If it's from the manufacturer, remember that's cobalt, so that's the radiation. You're just checking for integrity. Okay. If the integrity fails, the sterility fails. And what do we say? If in doubt, what are we going to do with it?
Throw it out.
That's right. We throw it out. Okay. So, what you're looking for holes, tears, moisture. All right. We want to make sure that none of that is there before we place that on our fields. In some things, we do check expiration dates, just depends. Um, we're just trying to check for policy compliance. It'll be facility based. Okay. We're looking at making sure that we don't have any type of legal implications pop up later. Now, I always wonder or get the question, why the back
Okay.
table first? Why are we putting everything on our back table? This is why.
You bought me some Ray-Bans? Oh, you blind, that's why.
Your back table is your foundation. Okay. It is the largest sterile field. Everything else depends on it. So the first thing we open is our back table. We're going to show you how to do that. From there, we isolate our sharps on one side and we open up our non-disposables on the other. We do pill packs last. Why? Because it maintains organization. It avoids a lot of clutter. It prevents contamination. Okay, now this one's big. When you guys are opening in the operating room, if you are You have a pack. It's away from you first, then the sides, and then towards you last. Okay? We're going to show you how to do it. But we're always trying to protect the field even from ourselves. Okay? Now, we do not open towards ourselves first because of sleeve contamination. We don't want to cross sterile boundaries. Think about it. If you were to open it towards you first, then your unsterile body has to go over the package to open the rest. This is why we go away first, then the sides, then to you. So then to yourself. Okay? That helps to prevent cross contamination or even the potential of cross contaminating. We never want our hands to cross the center or reach over. Okay, remember that. This is going to be really big once you guys are starting to open your items in the operating room. Okay, so we're getting ready to cross the line. We're entering into the sterile field. Okay, when you cross into the sterile zone, just remember that your margin of for error starts to narrow. Now you're the sterile person and you are aware of everything around you. If you lose that visual awareness, you lose control of contamination risk. That's how I was able to put an entire shoe on a student's back table. Not that they weren't doing awesome, but they had just for a split second, and I was probably ridiculous, but for a split second, I was able to have a shoe placed on a back table. Okay? So this is why we're understanding sterility. Your peripheral vision is going to be top notch. All right. You're going to be able to multitask better than you thought you would ever be. I promise you. And just by hearing my story, you're already going to be vigilant. You're already going to be looking like, who's, especially if an instructor comes in the room that's not one that's usually with you, you're going to very be looking like, what are they going to do? It's just situational awareness. Okay. When you're gowning, you're handling only the inside surfaces. Think back to the video from last week where they picked up the gown, it's like a book, opened it, and kind of swooped in. Okay, so up until now, the field was sterile. Now, again, we have to be sterile because now we've already opened up, we've already gowned and gloved. Now we're all sterile. The most predictable, valuable variable in the room is us. Okay? We are the most predictable variable. Here's a question that I have seen. What parts of the body are actually sterile in respects to your gown once you're scrubbed in? This was really big. What parts? Front of the gown, that's correct. Chest to waist. Sleeves to 2 inches above the elbow. Okay? Your gloved hands are also part. Yes. Back is non sterile. That is correct. Your back is not sterile. Your shoulders are never sterile. Your neck is never sterile. You see, I'm looking up, right? Unless you're in a total joint and you're wearing the spacesuit. But that's a whole different ballgame because in the spacesuit, even your head is sterile. But under normal circumstances, in a regular operating room, your neck, all of that, your shoulders, below your waist is not sterile. And can you ever just turn your back to the field and have a conversation as a sterile person? Right. That's not something you ever want to do. Okay. We get to our surgical count. The count is not formality, it is actually a safeguard. Okay. If the count is wrong, nothing else matters. But who performs the count? You're scrubbed in and the count has to be done. Right. We never want to because we do not want it to be left inside. The scrub is one. Who is the other one that, yes, you guys are on it. Your scrub and your circulator are the ones who do the count. Anyone can start it. As a tech, I can say, hey, let's do a count. Or the circulator can say, I'm ready for a count. You ready? Is it something that we do silently or is it spoken? Like, do we just go head nod? Or is it going to be a verbal? Yes, we're doing it out loud. We're not kind of like trying to use special powers to get this count done, right? We do a dual verification. It's all about accountability. It's all about legal protection, okay? We own our count. Period. We count before incision. We count before closing a cavity. So that could be, depending on your case, it could be, you may do 3 or 4 counts. Okay.
Oh yeah.
We
Wow. Okay.
count again at the skin. Okay. So we do a lot of counting because we want to verify that final count. We don't want anything left in the body. But here's the thing, what gets counted? We know sponges get counted, sharps get counted, and in some cases, your instruments. If you're doing a big belly case, instruments do get counted. That's why I kind of like ortho because we don't really count instruments because we constantly have um, x-ray is always there. Neuro, we're always under a microscope, but general, vascular, ENT, hearts, cardio, urology, you're going to count instruments, especially on those big cases. Okay. So how is this performed? You guys know I got a video. So again, yes, depends on the case and plastics. If you're doing like a cartilage or ear or a facial reconstruction, it depends. But if you're doing like a really large plastic case that involves bones and different other things, you can. Again, it's going to be facility based. Okay, so just kind of keep that in mind for plastics. But for the other like other um like plate like neuro and all those other cases, most definitely not neuro, general, the bigger cases like that where we're going inside of a cavity where something can be lost, definitely you'll be doing an instrument count. Okay, now as you guys watch this, I kind of like surgical tips guy. He is a heart tech, so a lot of times heart team does things slightly different, but he's going to show you with his nurse how a count before the patient comes into room goes down. So let's take a look.
Hey guys, welcome back to another Surgical Tech Tips video. We're going to be going over the proper counting procedure. I have a sterile field. We're about to start a case, and I'd like to go over proper, counting technique. This is a smaller case, so we're not going to be going through any instrumentation. We're not going into any body cavities, so we won't be doing a big count with instruments, but we will be doing a count with all of our small disposable things, needles, clips, blades, those types of things. So here's how it goes.
Ratex.
One thing to note, before you count, never take the tapes off of any of your sponges on the field until you start counting. It's a reminder that you still need to count the case. So I take the tapes off as soon as we start counting. We separate the Ratex as we count each individual one. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's 10 Ratex. Laps, same thing. I take the tape off. That's as a reminder to myself that this case is now being counted. 1, 2, 3, 4, 5. 5 laps.
Peanuts.
Peanuts, I have 1, 2, 3, 4, 5.
Hypos.
You guys may not be able to see this because the Mayo stand is in the way, but my circulator has their eyes on my field and she's watching me count each individual one of these.
And then trying to catch me riding dirty, trying to catch me riding dirty, trying to catch me riding dirty.
What was next?
Okay, shots.
Shots, 2, 4, 6, 8, 10.
10. Hypos.
0.
0 hypos. Any vessel cannulas?
No vessel cannulas.
No vessel cannula. Vessel loops.
Vessel loops, I have 2, 4, 1, 2, 3, 4.
4 total. Bovie tips.
Bovie tips. Always show the items to your nurse. 1.
Is 1. Blades.
Blades. I have 1, 2, 3, 4.
4 blades.
4 blades on the field.
Any umbilical tape.
No umbilical tape.
Inserts.
No inserts.
Hemoclips.
Clips. I have 1, 2, 3, 4, 5, 6, 7, 8.
Okay, that's correct. Sutures.
Sutures. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13.
13.
13 sutures.
All right. Anything else we need to count?
Nothing else. I have fluids on the field. That's it.
All right. Thank you very much.
So that's proper counting procedure. It's important to, I know AORN really wants us to not count in twos. On some cases it's really, really hard to try not to count in twos, especially big heart cases where you have like 160 needles or something like that and you're counting each individual one. It can be pretty cumbersome. So a lot of the times we do count in twos, and I know there's a lot of techs out there that do that. So some things to note. Obviously we did a case, so I wasn't able to finish up that video with an end count, when we started to close the incisions. So things to note for the end count. You start your count when the surgeon or assistant first starts closing the incision. Whether it's an open body cavity and you're closing up peritoneum, in the belly, that first layer that they're going to be closing up, once they decide they want to start closing, that's your cue to start counting. You're counting the exact same things, obviously, that you counted before the case started. The most important thing to note, though, is the way you count. You have to start at the field first, count everything that you see on the field, as far as if you're starting off with laps, how many laps are on the field? 1 lap on the field. Okay. Move to your Mayo stand. How many laps are on the Mayo stand? 2 laps on the Mayo stand. Okay, great. So that's 3 laps. And then you move to your back table. Back table is always last.
So real quick, why do we think the back table is last from what we know of the purpose of our back table? And so we don't get confused, what he's saying is we start with one thing all the way through. So your case has already started, okay? And we have laparotomy sponges on our field. We're going to count laparotomy sponges on the field, laparotomy sponges on our Mayo, then laparotomy sponges on our back table, and then we wait because remember we have a kick bucket. And 9 times out of 10, especially in big belly cases or even heart cases, we place laparotomy sponges in the kick bucket. So we're going lap Mayo, lap field, lap Mayo, lap back table, waiting for our circulator to count laparotomy sponges off the field before we go to the next item. This is really important. I want to make sure you guys understand that. We start with one item, we go through one whole cycle, then we go through another item, one whole cycle. When you have instruments, you're counting hemostats on the field, hemostats on your Mayo stand, hemostats on your back table. And then we move from there all the way through. What you see over here is, sorry, I went too fast. What you see over here is how we keep account of it in our rooms. In every operating room, there is some different form, right? Because there's a lot of different ways to do things, but you'll see some type of board in there where you can where the nurse is writing, what you're counting. So not only you know, but everyone in the room knows what you have on your field. Does that make sense? Because I have seen this kind of be one of the things that students do get missed in the lab. Okay. So I want to make sure that we were good. Now, this one we're really good at. We know that if it's not labeled, we're trusting, we're verifying, but we're not giving our surgeons anything if we don't know what it is. That's basically what this says. Okay. If it's not labeled, I don't see it. It's not there, right? Clear fluids, we already know, are the most dangerous because just from pharmacology, we know how many clear fluids we could have at any given time on our fields. Now, my slide deck wanted to go to this so bad because this is really big. Okay, the timeout is very important. This is the last checkpoint before harm becomes irreversible. And instead of kind of going through everything we have to do in a timeout, why don't we watch it in real time? Okay, now keep in mind they're highly scripted. We don't talk like robots in the operating room, but the sequence is pretty dead on. So let's take a look.
Record number is okay. If we can get an all stop for our pre-procedure timeout. We have patient Luna Lovegood, medical record number 01234567.
Matches my chart.
And we are consented for left thumb replantation versus revision amputation.
That matches the consent.
Thank you. Site and side are marked. We have allergies to adhesive, aspirin, and ciprofloxacin. Patient received their antibiotics?
Yes, I got cefazolin 2 grams, and you are in the green timing wise.
Excellent, thank you. In terms of other medications, at the end we'll use some 0.25% Marcaine without epinephrine. This was an open wound, so we did not do an alcohol-based skin prep. In terms of heat source, we have Bovi.
Bovi will be holstered while not in use, and there is sterile saline in the field.
And we are on 30% oxygen with no cuff leak.
And no other flammables are going to be added to the field.
Okay, in terms of procedure-specific items, we have mini C-arm in the room. Are there any other concerns that anyone has?
I had a question for you about vasoconstrictors. Avoid phenylephrine and vasopressin.
That'd be great, thank you. All right, thanks everybody.
All right, so that's how it goes. Now, you'll notice that in this particular instance, the patient's draped, everyone's pretty much ready to go. Now, per ARN and AST standards, timeout has to be done before incision. That's it. Some facilities prefer it to be done before the prep. Some facilities do it as you see right here, patient's already draped. It just has to be done before incision, okay? Incision. I have seen concepts asked about that, so I kind of wanted to make sure we emphasized it. Now, we look at sterility is decided in seconds, right? You place a suture packet on the edge of the back table, it slides slightly down the side. Is this sterile? Can we still use this? No, we can't. And it happens, okay? So the biggest thing again is not only did you recognize it, but how do you fix it? Here's another one. You're draping a basin stand. Do you unfold the drape towards you or away from you first? Remember, going back to the concepts, do we ever want to cross over? Right? We always away. These are just different things that you don't want to get caught up on because when you're in the lab, you're in your groove and you start doing things, okay? All right. So when we looked at everything, we learned about planning, right? We know that that preference card is that roadmap. It's prediction. It's the blueprint. It helps us to determine what we need for our surgical procedures. We know that we're doing checks. We're checking the patient's BMI. We are listening to the diagnosis. We're making sure we have special equipment, positioning. Where planning helps us to reduce any surprises. Now, what is the opening sequence? Can we just grab our items and just start opening them up? Or is there something we need to do first before we open them? When you guys get in the lab and you start opening stuff, what are you going to be doing before you even open them? Aha, you're checking for holes, you're checking for tears, you're verifying, you're inspecting. Okay? Also, when we're opening a item, always remember away, side, side, then towards. And picture it in your mind when you get in the lab. You're like, I'm going to go away. Then I'm going to go side, side, and to me last because I don't want to contaminate. Okay. So always kind of picture that in your mind.
But when you open away, doesn't your hand cross in front of the items
So
anyway?
great point. And I wish we were in the lab. So when you get in the lab, it'll make sense. So picture it. The item is closed. There's nothing open. So the first thing you open will be away, but everything else is still tucked in nice and tight. Nothing can get on it. So you go away first, everything's still tight. Once you go side, so you have this little area, but you're not going to go back over it. So then you take this side, you go over, and then the only thing left is towards you, and then you don't go over it again. So that's why um if you ever open up a Christmas package, I think this would be the easiest way, and you have the flips, try opening away first and notice that the majority of the package is still going to be wrapped. Then we usually go to the left or right, but I usually do left. So then now this part is open, but I'm not going back over there. Okay. I'm going to make sure I put my hand down on this side and then I grab the other side that's not open and then I open. So then now you have like a moon that's sterile. So then you're not reaching back over that. The only thing left is to pull the little tab away and you keep your body kind of moving back so that now you have an open space that you haven't reached over. Does that make sense? Okay. Because that's really one of the big ones. Okay. You guys do have a Quizlet. I went ahead and placed it in the archive just to kind of have additional resources. Make sure you guys are listening to the Scrubbing Sessions little podcast. Another just resource to kind of help you guys get in the groove as you guys get closer and closer, not even to the cumulative exam, because I know you guys are going to do really well, but as you get closer to the actual field. Okay. Just keep that in mind. For those of you that are watching the playback, I want you to explain how improper labeling of irrigation or medication solutions on the sterile field could lead to preventable patient harm. I want you to also describe the specific steps we as CSTs have to follow just to make sure that medication accuracy happens on the sterile field during high pressure situations. And I want you to discuss the temperature regulation of irrigation solutions. What happens when they're in surgery? How could improper temperature control impact tissue integrity and ultimately the patient outcomes? Today, we kind of are bringing everything together. I'm hoping that you guys are feeling more comfortable as you guys get closer and closer to Mod 4, where you're going to be doing this really soon. We talked about how to break down those surgical terminologies, but not just break them down. Break them down and bring them to why it matters to us in the operating room. We looked at case planning. We looked at the sterile setup mechanics. We already know about medication safety. We looked at the surgical counts. And this all ties into universal protocols. Each element reinforces the same principle: preparation prevents errors. With that, what questions do you have for me? I have a question for you guys before we get out. Is there any way to review? So if you check, so we cannot give out like questions word for word. So what we did is we went through everyone's midterm. If you go to the feedback area, it'll tell you areas to kind of look at. That way you're not just memorizing the questions themselves, because on the cumulative exam, it takes those same concepts to the next level. I'm gonna be transparent. You'll see some of the same concepts, but you're not gonna see them asked in the same way. It's gonna be mirroring closer and closer as you get further and further the program. You start mirroring more CST from what you learned here, and that really does help. Because yeah, like she said, it's rewarded. Because right now we're like at 80%. Almost everyone that's been taking that CST, based on how we've kind of like done these questions, they're passing. So it's to kind of really grab what you know, build up that confidence. So no matter how you see that question, you're able to answer it based on the concepts that we're learning here. So just keep that in mind. But the feedback is in you should see feedback now from the midterm, week 6, from 1 through 6, week 7, and then next week I'll be doing week 8, week 9, and my goal is to get week 10 in before you guys start taking that final exam. Okay. You guys also have career services coming up, so I don't want you guys to forget that. There is a Quizlet, and with that, y'all, I can't believe it's getting closer. Like, you guys will be in Mod 4 soon. And I want you to claim it, okay? I know we have a final. I know it's stressful, but I want you to claim it right now. You will be in Mod 4, okay? With that, I do want you guys to have a wonderful rest of your evening. Have a wonderful weekend, and I look forward to seeing everyone who can attend next week's live session. Good night, everybody.